There are measures that do have a purpose and do affect clinical quality outcomes, and they make sense. Okay, this gives me some confidence in what the program is supposed to do, and then they lose it. They lose it in the weeds every time because small practices are never going to be able to compete with the large ones. The moment you have to be compliant with government auditing, you are spending out of your bottom line to meet that. The fact that you're getting an incentive does not outweigh the time you have lost working on it, even if that incentive is equal to the amount of payroll dollars spent on it in employee training.
A safe haven for innovators to go off the rails.
Welcome back to the Off the Rails podcast, a show about the runaway train that is our healthcare system and the innovators working to take it off the rails. This is your host, Sydney Haytoff, and today we are joined by Craig Epstein.
Craig, nice to be here.
For all the listeners out there, Craig and I worked together for a long time in a prior life. Craig can attest to just how rough I am as a team leader.
You have your
Rough.
moments.
I used to say, what was it? Firm but fair and fun. The 3 Fs.
I'd give you firm, occasionally fun, and for the most part, fair.
Okay, 99.9% of the time.
Absolutely, but everyone remembers the 0.1% when it happened.
Yeah, it's fair.
That's why they're called outliers.
So, see? Firm, fun.
Definitely, I would never have taken it back. It got me to where I am today. 90% of what I know is because I had to put up with you, which was absolutely worth it. And I hopefully look forward to doing it again because the industry is awful.
Everyone heard that? He wants to do it again. Preview for
I know
what's
a
to
good
come.
thing.
Well, preview for what's to come for our friend Craig here. Craig, thanks for taking the time. I wanted to have you on because it is not often that the industry hears from revenue cycle experts aside from myself. And I'm sure that they're all fairly tired of hearing what I have to say about the state of affairs in our industry and how the revenue cycle impacts or doesn't impact dynamics. I also want, though, to give people a revenue cycle standpoint on some of the topics that the folks in our space talk about quite a bit. No Surprises Act. Probably won't touch on the what's it called? The Consolidated Appropriations Act, because it's not.
I'm not too familiar with that. That's probably for the best.
Exactly. I didn't think that you would be. It's part of the NSA, but not really. But yeah, I basically want to just catch up and get a sense for how things have been in the revenue cycle world. It sounds like it's not been so pretty, and want to hear why. But actually, can we start off with what are the latest? Is it still called MIPS these days? Macro?
It is still called MIPS.
Oh, okay. MIPS.
And it's
Merit.
joke.
The Merit-Based Incentive Payment System. Stay macro. Okay. When we first started implementing MIPS, when it was in its first form as PQRS, or the Physician Quality Reporting System.
You over that?
Yep. It was the same. It was primarily primary care based. Would you say that is still the same, or that still stands today with MIPS? The reason why I ask is because in my dealings over the last couple of years, I've quite frequently been asked about quality reporting, and not really reporting, but quality analysis and quality vetting, quality criteria. And people oftentimes point to Medicare data, believe it or not. And my first response to people pointing to anything coming from Medicare quality data is that you don't know what you're talking about. Otherwise, if you did, you would know that this Medicare reporting data is a joke. And
I think I agree with that.
Most of the time when I speak with physicians about quality reporting, we all kind of chuckle knowing that it is a joke in its current state and that there is lots of work to be done to actually get down to the nitty gritty around quality and what drives quality, and the fact that quality could be different for different people in different contexts. And this one-sided or 2D view of quality that we currently, are dealing with in the industry is very limited at best. Would love to hear your thoughts on that, having been in the weeds for the last few years.
Okay. So I do believe MIPS is absolutely, it's as intended, it's supposed to be about the quality of care. It's supposed to be about patient outcome. You look at any MIPS quality measure, and at the bottom they have an analysis about why doing this measure will improve this outcome and benefit the patient. The issue is that the way the system was designed, if a certain measure is reported at a certain rate and a certain quality rate across all the different specialties and providers out there, it will eventually be done. Unless it's measure 130, the documentation of current medications, because they'll never get rid of that one. Because then some providers wouldn't have anything to report.
Wait, hold on. Let's dig into that for 1 second.
Okay.
Even I remember that measure.
Of course.
130. Wow, it still has the same number too. That's
Yeah, but now you only get 5 points for it, and everyone still reports.
Yeah, they got to give you a gimme somewhere. Interesting. Yeah. With what you were saying though, just before, essentially, when a lot of physicians, a lot of patients, a lot of volume comes through for any given measure, or excuse me, a high reporting percentage, a high numerator, a high quality percentage comes through for any given measure. Once they start to see that there's less variation, they sunset the measure because essentially it's become too easy to report.
Yeah, because the whole program revenue neutral, or so they say, the incentive that providers earn for reporting very well is benchmarked or earmarked against the money that is lost by the providers who either don't report or report unsatisfactorily. So if you got providers across the country who are reporting measures 47, 130, and 238, I think, that's advanced care plan, documentation of burn med, and one of the stupid blood pressure or BMI measures at 100%, then everyone is just neutral. Everyone's doing the same thing at the same rate. It's not raising the quality of care anymore. It's become the de facto standard.
Interesting. Okay, so then would it be fair to say, and I say this knowing the answer, but I'm leading because this is something that I've tried to get people to understand with regards to other quality measures and reporting programs, such as the bundled payments for care, whatever, BPCI, because we've heard from some prior guests that a lot of these quality reporting programs are a race to the bottom or a race to the top, based on what you're saying. But
I agree.
essentially, there's only so much quality that you can pull from a given measure or a given context. And once everyone gets fairly good at performing, a certain measure, that's not worth it to be considered in the context of the reporting program because, like you said, revenue neutral. And so some set of providers are getting paid more because another set are getting paid less because of their failure to report.
Correct. So what's the question there?
Yeah, I was just gonna say, I'll reiterate the question. Would you say that quality measures overall represent a race to a certain number that then makes them less interesting to report on? Basically, the question is such that, are we picking measures that are too easy, or are we picking measures that are truly impacting quality? It seems as though if there are measures that could be quote unquote gamed, and to the extent that a large percentage of the population is reporting favorably for those measures, then there are not measures that should or are really driving so much value. But I guess that's not necessarily the case because the washing your hands is a quality measure that
hospitals still don't do it.
Does. Oh yeah.
Not saying this lightly, but because I genuinely believe it, when I'm almost 100% positive that Vassar killed my mom because she was getting infections from all the different catheters and intubations and things when she was sick. And it was never because of her actual reason for being in the hospital. It was always because of some device or instrument that they were using that wasn't properly maintained, or a catheter that wasn't cleaned properly or replaced in a short enough time, causing an issue. It was constantly things that could be attributed to minor hospital negligence. But when you look at the rate for people getting infections in hospitals, it's through the roof. That's why it's so nice. You can't be near sick people when you're getting an ASD surgery. If you're in a hospital, you're near people, and then your chance of infection skyrocket.
Hold on. Dude, first off, I didn't realize that was what happened. I know.
Okay, let me go to the mom story. You can include whatever you want in this because I'm comfortable with.
Yeah,
Mom-
good. Hold on. But I just want, we have to talk about this after that also.
This is a bajillion.
Yeah,
Take
but
whatever
I
you
want,
cut it
I want
off.
to make sure you're like suing the dick out of the hospital, yeah?
Can't do it
Why?
because infection. You can't prove someone was negligent when there was an infection. They happen all the time. How am I going to prove someone didn't wash their hands properly, or didn't use the right PPE, or
Yeah,
didn't?
but if it's a hot, Jesus Christ. But
Also, 2.5 years on the statute of limitation for medical stuff in New York, I believe. So it would already be past that date.
yeah, but maybe not if maybe not if it's part of a class action suit or something. If it's like a repeat thing with that hospital. Jesus, fuck. Oh my God, that makes me so mad. Sorry. Yeah, because I was gonna say it didn't make sense. She wasn't that sick, was she?
Depends on how you look at it. Got acute pancreatitis, really bad case. My understanding with her acute pancreatitis is like a gallbladder having stones. Her pancreas had masses that were forcefully expelled, and they caused a rupture of the pancreas, which leaked the bile into the abdominal cavity.
Oh, that'll kill you
Wait.
real quick.
It burns your inside, literally.
That
It's an
happened to. Remember my girlfriend? Actually, yeah, you would have remembered Irie, the one that I lived with when we
Yep.
first started working together. That happened to her sister. Literally, same thing. Overseas, she was studying abroad. She had some crazy like tumor or something, and it was in her pancreas. It exploded, and it burned out her entire stomach, basically.
Yep. And when you have acute pancreatitis as bad as my mom did, they had to put her into a medical coma. And I believe it was at least 2 months. It was a long time I track of the actual order of operations here. But so they had her in a medically induced coma, and they basically put all these different tubes in you, and they say the solution is to let the body slowly flush out all the decaying and burnt material. And I saw the bags they would change from these tubes. The liquid that came out of her abdominal cavity, it was like yellow. So even months later, it was still, her body was doing absolutely everything it could do to clean herself out. But she was constantly getting infected. I walked in one day and I could see her eyes were glazed over and she had tears in her eyes. And I'm like, Mom, what's going on? And it looked like a migraine, but I had no way of knowing. She could barely communicate to me because she had such an intense migraine. And then I was like, okay, I'll get someone. And she didn't want me to get someone because the way they administer the medicine via the tube, because she wasn't able to eat at that point, was so forceful that it made her uncomfortable because her insides were. So it was just a vicious cycle where everything they were doing was only exacerbating her illness and her level of comfort in the hospital where she was already stranded, and it was just a losing fight. They wanted, when she was still stuck full to send her to St. Joseph's in Jersey, the rehabilitation. And I looked at the head nurse and I'm like, she can't lift her arms. How are you going to rehabilitate her right now? And they didn't care. They went ahead and did it anyway. And then they charged us for the ambulance. It was like $3,000, some nonsense for a 40-minute ride. And they sent her to St. Joseph's with an infection that St. Joseph was not adequately prepared to treat. 4 days later, he was barely responsive, and they had to ambulance her back, which we were charged for, to VAPS, where they had her in the emergency, what is it, not the ICU, right? Intensive care unit? Is that it for, they had her in like the ICU or something for days until that infection came down, but it kept happening, and it kept happening, and it kept happening. And finally, one hit her that her body couldn't recover from, and did her in. At least 7 or 8 that I'm aware of that affected her continuity of care that they had to adjust for every time it happened. And that's one of the better hospitals for more fun. They opened right at the beginning of COVID when the hospital was filling up, and in their infinite wisdom, they put her in the COVID wing.
Yeah, fucking new ants.
Yeah.
Oh,
Yeah. Hospital scares the crap out of me. Even the good ones are dangerous.
Yeah, they're all fucking dangerous. Specifically for what you just described. Hold on, I'm looking now. I'm looking this up on the leapfrog thing. So basically, this concept is like something that's interesting. It's something that the self-funded employer, self-insured employer space hones in on is quality. And it's almost like a fake measure because, like, how do
I
you
don't
really,
think the quality measures are real
who's really
because,
checking?
and even if someone's checking, like, is it actually improving the outcome for the patient? So, for an example, let's look at patient A. Let's say they're morbidly obese and they're seeing the orthopedist. Obviously, it behooves the orthopedist to refer the morbidly obese patient back to their PCP saying, you should lose weight. You should try non-invasive options. You should take care of yourself first before you resort to orthopedic surgery. And yeah, there's a measure that the BMI measure has that as an option, referring them to weight loss counsel and nutritional guidance and all that stuff. But if you're a good doctor, you're already having that heart. If you're a bad doctor, you are saying the bare minimum you can say, so you can note that you did that measure, so you can get the hell out of noting that measure any further. And you really improve any outcomes in either scenario there. The one where the treatment was good, the treatment's good, and the one where the treatment's bad, it's still bad, but now it's being noted like.
Yeah.
And there are some outcome-based measures that require a lab result, like the diabetes A1 test or some other strict documentation that like perioperative plaques was administered, which I agree is important, but that's really always administered before those surgeries, like
Yeah,
total
those are
knee
on
repair and whatnot.
standing. Those are on standing order. I'll
Yeah.
never forget.
My assumption during the PQRS days were like some hospitals in Kentucky must not be doing it. There must be a reason for this measure to exist, but I've yet to see an example where a hospital wasn't doing those things. And when it comes down to it, I think that reason MIPS lost its way is because it has to be tailored around the fact that it is a hindrance to the bottom line of small practice. And because of that, there's tons of little loopholes. There's tons of ways out of reporting requirements. There's tons of little shortcuts that are in the final rule and the guidance that you can take advantage of, but at the cost of what? The chance to get more quality care reporting data and provide better clinical quality outcomes because now you've found ways to report less data. A great example is when they sunset measures because they have too high of a positive reporting rate, they have to add more measures to replace, right? They don't replace them at the same rate that they sunset them. There's an imbalance there. If you're an anesthesiologist, you have 3 measures from. If you're an intraoperative neuromonitor, you're shit out of luck. It really just depends on what your specialty is. But there was a key part I lost. I can't believe I lost.
Specialty measures, not enough relevance.
Oh yeah. Something in the measures. Here we go. It's back. Thank you. The new measures that let me see if I have, you're going to really appreciate this if I have a quick. So like some of the measures they retired, 375, functional status assessment for total knee replacement. Okay, I guess everyone's doing a functional status now. I sincerely doubt it, but that's fine. And then
which is insane though when you think about what that represents. It's like, how are you not doing a functional status?
I know the whole thing is a little scary when you go too deep. But some of the measures they added, and don't overthink this until I get to the final point on it because it's hysterical. 485 for improvement in patient reported its severity. Okay, I don't know what specialties that's going to be a quality measure for. 493 adult immunization status because apparently PCPs don't note that down anymore. So let's talk about 493 adult immunization status. There is a provision within MIPS where if you report a measure that is new in that year, meaning it does not have a benchmark yet, it is worth 7 points, even if you report it at 100% not met. So what do you think I do when a provider comes to me in the end of November, having not documented what they're supposed to do, having not done anything they're supposed to do, and they need a obviously dirty solution to survive the MIPS program, but also still be on the right side of compliance and do what they're supposed to? I immediately go through the new quality measures and I check to see if their billable services have any eligibility. And I say, report this. And they're like, we don't do that. I'm like, okay, new measure. It'll get you 7 points just for recording 100% not met. who's benefiting there? CMS wants to see data, so they offer those 7 points, but the data they're going to get is useless because consultants and RCM, revenue cycle management, and providers who know what they're doing, who have read the final rule, will look at, okay, how can I do the least amount of work possible? They just took away 2 of my measures. I don't want to train someone to do more this year. I'm too busy dealing with fallout from COVID, bringing up my new ASC, all this other stuff. Let me just report this measure. And there's four of these 1, 2, 3, 4, 5, 6, 7, 8, 9 measures, at least 4 of them. I can tell just by the way they're named that they use the standard E&M utilization code, which means if you're in an office setting, chances are you can report it at 100% not met and get your 7 points for multiple measures. And I understand why they do it because
hold on, they also they also make it that from what you're describing, it makes it seem like it's been easier to report the measures that you didn't do than it was in the beginning.
yeah, and they have to, because if you're a small practice and you only have 5 measures available to you and they sunset 2 of your measures, but you're not a part of one of the EMA clusters, you're now out of luck. You have no other options but to immediately go to one of the newer measures and hope you can get something out.
And that's all because of the lack of relevance around the quality measures that exist for across all specialties. So basically, certain specialties just don't have measures that they can report, and that's just because the specialties that they treat are ones that CMS just forgot about.
Yes. Some of the measures are such a problem. Why do we need this? And then there are measures that do have a purpose and do affect clinical quality outcomes, and they make sense. Okay, this gives me some confidence in what the program is supposed to do, and then they lose it. They lose it in the weeds every time because small practices are never going to be able to compete with the large ones. The moment you have to be compliant with government auditing, you are spending out of your bottom line to meet that. The fact that you're getting an incentive does not outweigh the time you have lost working on it, even if that incentive is equal to the amount of payroll dollars spent on it in employee training. It's still time taken out of their day, time taken out of their documentation habits, time taken out of their training. And if you're not a big practice that can eat that cost, you absolutely feel it, whether you start in January appropriately or you contact me in November because you have no clue.
Wow. And the whole point of quality reporting and driving quality is lost then in the format, gaming the system and in the format of the system itself, right? Because it's a net neutral, you said, it was the same thing, net neutral incentive program, so that they have to take the penalty dollars and apply them to, or they remit the incentive dollars from the penalty dollars that they apply to folks, to providers. And so it doesn't matter really necessarily if you're reporting or performing XYZ action, because even if you are, you're not going to get incentivized, or if everyone's doing that same action, you're not going to get paid for it because it should be getting paid for by people not performing other actions. And so if there's an imbalance, that's why they get rid of it. If they get rid of it, that kills the point of having the measure.
You did the one that started.
Exactly. And so what's the point of having
I never thought of it that way. That's the first. No matter what you do, someone's always not performing. That's how you get your incentive, which means the program on its own is inherently a failure.
Exactly. So it's interesting. I've never really thought of this net neutral concept that way until literally just now, where it's like, how could you have a reporting program that's net neutral? You're essentially incentivized to find areas where people are sucking. And it's not even necessarily, and it's not even necessarily that they're actually really sucking in those areas. It could just be that they don't have the resources to report.
So let's talk about that before you.
Wow. So that makes the rich richer then, essentially, based on what you were getting at.
I'm just about to hit on that.
Yeah.
Who do you think are big? This is anecdotal. I don't have to support this, but who do you think in your education are the 2 types of providers, companies, whatever you want to call it, that fail the most?
Independent specialists.
Small, without resource.
Yep.
And then the ones that are so big they don't give a shit.
The hospitals.
Probably some of them. I know a lot of the hospitals are a part of the, not MIPS, but the advanced payment models.
Oh
which
yeah,
gets
yeah.
them out of doing some of the additional work because they to game it even further. But in my experience, the providers that take that penalty are the ones that can't afford not to, because the work it would take to get compliant isn't worth it if they're only making that bare minimum for the threshold to be eligible for the program, the
Sorry,
$90,000.
so sorry. You're saying that the providers who take the hit are the ones that can't afford. Oh, I see what you're saying. Yeah, to not take the
Yeah.
hit. Yeah, because they can't prepare.
Think of it this way: if I'm a doctor in Kentucky, rural, underserved area, and I make exactly $90,000 from Medicare a year, which puts me in eligibility for the program, and means I don't report, I'll take a $9,000 hit. What do I do? Hire a whole nother employee for the entire year to make this work? Do I make someone work extra hours and then pay them overtime? No matter what I do to satisfy the program, I've heard my practice way, at least in the short term, and probably in the long term if my patient population doesn't support it. And if I'm only making $90,000 off Medicare, my patient population probably does not support the extra resources I require. And then the ones that are too big and they don't care, the ones that have multiple hospitals administered by a third-party biller that just reports everyone as a group and takes a 2% penalty because they're not aware of the rules. Yeah, they lose 2% of each of their providers, but they don't care because it's only Medicare, and they're seeing bajillions of patients who are Blue Cross Blue Shield, United Healthcare, and whatnot. And the pennies they're losing on their Medicare patients in the hospital environment are going to the people who did 80 out of 100 on their quality reporting, or 90 out of 100. And they're not getting the full 9% positive adjustment. They're getting some fraction to balance it out against the people that lost it. So if you could have people taking a 9% hit, and then top earners in the MIPS program only gain like a 2% positive adjustment. Imagine doing all that extra work. So when you get paid $90, you now get paid $91.75.
Yeah, the right intentions, I think.
Absolutely. Executed poorly. I was actually talking with someone before, and they had a perfect word for it. Either it was called perverse intentions or perverse consequence. I think it was perverse intention. Perverse intention, what I have when I look at MIPS. I see the different rules and I say, you should report this at 100% not met because you're going to get 7 points out of it and you're going to satisfy the program. From the MIPS side, that looks all hunky-dory. From how I see it from this side, 100% exploiting the program and inverting the data in the program.
Yeah. Yeah. How could you look at it and not try to game it? Especially when your job is to support your client.
I don't remember at what point back in the day when we were working together that you got reassigned and they were shifting around, but I have a specific memory where I was on my own in MIPS, I think, and no, it was still PQRS. It was still PQRS, and we were not able to report for some intraoperative neuromonitoring because there was nothing in PQRS that they could do because they are non-patient facing. And so I on the phone with the quality QPP, quality payment portal, which is the administrators of the program, but not technically CMS, even though I'm pretty sure they are. And I asked them 90 different ways Sunday, my providers are eligible. They have no services that they can do any reporting for. What can we do? And they gave us no good answer. Okay, then I can't report anything because there's nothing to report. So if CMS still flags them, I will file an appeal and I'll demonstrate in the appeal X, Y, and Z. And so that's exactly what happened. And then I wrote a very long appeal, basically demonstrating exactly what billable service they did, how these services were done remote with a provider that's never seen this patient, and why it's done like, which I shouldn't have to. CMS should be familiar with IOM services at this point because they credential IOM providers.
And they pay them.
And they pay them. How it's just you can't possibly apply the penalty to these providers, giving them no avenue to successfully be compliant. And they didn't give a shit. Still got the penalty. That one hurt me. That's where I first became cynical.
Yeah.
It still sucks. They're still trying to make changes. They still improvement activities are like 90 days still. Promoting interoperability, how you use your EHR to do the communication of patient data is now 180 days, but practices still get an automatic exemption. So you can bet that I will never recommend promoting interoperability category to a small practice. And just for the podcast, small practice by CMS size is 15 or less providers. Small practice still be pretty big. So it's just a poorly designed.
Have you seen
They
any?
needed to do like a 2-year pilot and then go back and rework it based on what they learned. And they didn't. They just kept making micro change after micro change, and now it's bloated into some behemoth that that everyone has to deal with.
Sounds like managed care.
Which I guess is how everything ends up if there's no checks and balances in government.
That's crazy. What about quality reporting programs are flawed inherently?
Inherently, good purpose, bad outcomes.
Have you seen any commercial quality reporting that has hit well?
I haven't seen any commercial. I haven't seen any commercial quality reporting program that have required my providers to participate. So I've never suggested participation in them. I do know once upon a time I saw at least one Medicare Advantage policy that was paying some sort of incentive based on reporting, and then they asked the providers for additional reporting, and it wasn't even enough to justify doing the work to continue getting that.
And with regards to doing the work to get the incentive, would you say that's literally just some type of entry somewhere, data entry somewhere in the context of the provider's workflow?
So that's the part where I feel worst about this program. That the way it's currently done puts a lot of onus on the RCM company for making sure the providers are compliant, or whoever's doing their billing internally if they don't have an RCM company. Front office staff has some sort of burden too, because you can use those intake forms to document certain measures like the advanced care plan if you'd want, because then it's right in the doctor's face. They can talk about it, they can say that in the note, and then immediately just check it off. And the providers themselves. But the issue is that the way the work gets leveraged is often indicative of the fact that the providers aren't educated enough to know how to delegate that work, and that they don't have the resources to delegate it properly. Because in an ideal world, you front office take the intake forms from the patient, tells the provider that they're here, they'll put them in whatever room, intake forms get uploaded, and the provider already knows the 9 measures. And he knows that he's doing an E&M visit or he's doing a follow-up, he should know what's eligible. And the reality is he should only have to make 9 clicks in addition to his regular notation to say, yeah, did this, yeah, did this, yeah, did this, yeah, did this. It's never set up like it's always set up they're manually typing it out, or they have multiple templates to accomplish it, or they have multiple templates that their mid-levels use before they even get in there. And then you have to do the review on the back end to see how often they got it right, which patients they forgot to do it for. Did the charge pass system not work with the codes because there was no fee on them because they're quality reporting code? The list grows longer and longer when the solution is just really simple. Give me 2 navigation bars, 1 to configure MIPS, and then 1 with my chosen measures on the note, so I can just click a radio button to say yes, no, exclusion, exception, and then it'll populate something in my note where I can add a little extra if I need to, and then be done. But it's never like that. You have the option of doing quality data code, tell that the CMS that you are documenting everything, or if your EHR is 2015 certified, which pretty much all are, but do they also support your measures, which most of them do not. If they support your measures, you can use a clinical notation method, and then you have to hope that the way the EHR wants you to do the documentation is in line with your best practice to make it optimal. Because if it's not, then you're going right back to quality data, which is what I recommend 90% of the time, because after looking at systems like Health Monitor and Allscripts, I would rather claw my eyes out than do the clinical notation way.
Yeah. So basically, no easy way, no streamlined way to report.
Some EHRs, some registry vendors do it very well. Some do it very poorly. There's no 2 solutions are created equal. Mingle. If I use Mingle, it takes a little longer because I have to upload the data, I have to wait for the return on it, and then do the performance afterwards. But it's all there, it's all clean, everything works. If you're in Dr. Chrono as an EHR, which means Their supported registry vendor is Elfmonic. So 2 things I hate in a single sentence. There is a charge pass that it's not really a charge pass because it's not for billing, it's for the reporting, but there's a eligibility path that determine which measures you are eligible for and what numerators are being satisfied based on the documentation or the QDC code. And you have no control over getting it in the system that spits out the data for you, but it usually works unless you're trying to do it in the last 2 months, in which case they switch it to manual to make it suffer. And it's just not no value in it. If you could do it under a certain amount of time, then I would say it's valuable even if you're not reporting it to government. It would be valuable for personal use. But it's not. Even the most efficient ways still require that have people regularly trained in your office and know what to do in order to meet the strict input requirements to make those systems work. It is just another workflow on top of your pre-existing workflow, and I've almost never seen it make the process simpler, only more complicated.
Wild. Yeah, I wonder, and I'm now thinking back on what the workflow was when it first started, these quality reporting programs.
We did standing orders.
For sure. And the standing orders and also baking it, the reporting into the existing workflow so that if someone needed to check off the fact that medications were reconciled, then they did so in the course of their standard process, or at least we baked it into the standard process.
What should
One extra click. And I guess absent the ability to do that, which how could, with the measures changing so frequently, how could it really be? I guess there should be the ability, but
yeah. No, I could answer that. They can't adapt fast. And the reason is because you can always look at the new measures, open up the documentation, say, what are the QDC codes that I want to use to report? And you can say, I'm adopting this. I'm going to put QDC code in every single note, or I'm going to make a template that inserts it for me. But if you're a small practice and you have in-house medical billing and they're just sending claims and doing appeals and denials and whatnot, and they're not really understanding how the billing works because they don't need to, they're not going into your reporting system and identifying what's been done right and what's been done wrong. You're not going to be able to work with your EHR to develop the right clinical notation pathways to make it make sense. And try doing it with not with Dr. Chrono. Some of the measures required you leaving the note, going somewhere else, clicking a drop down, picking the right item out of multiple. They're not in alphabetical order. They're not labeled right. It's a scroll bar. And then you may have to go out and fill out more depending on what you select. And if I was the provider, thank God I'm not, I would have already, because it's a waste of my time.
that's nuts, man. It makes me think about what we've been doing in the context of our care coordination flows and recording information from patients and helping providers, like helping augment essentially provider documentation by implementing certain questions and workflows with patients. It makes me wonder what and how we could potentially help them in these contexts without it really impacting their flow. And frankly, it makes me wonder, like, how now I'm thinking back to the horror stories. Yeah, how could any group be expected to just randomly implement something that is completely out of the context of their standard workflow? And
I had to either conform to a third-party registry vendor or the EHR notation format that the EHR decides.
yeah, and that actually, yeah, Jesus, and that has no benefit, frankly. There's zero benefit. They might as well just take the hit. Because even if they didn't take the hit, it's not guaranteed that they're actually going to get some incentive, or at least an incentive that offsets the cost, to your point before.
Yeah, so if someone in a really worst case scenario, they know they can't possibly positively report. Let's say it was March 31st, the last day to report, and they came to me and said, I need a solution. I could do it, but it would be 4 new quality measures that have a benchmark that allows me to report not met. It would be documentation of current medication, or whatever they say they do 100% of the time, so that they can get another 5 points there. It would be 5 out of 6 measures. They would lose points there, and I would be like, okay, here are the improvement activities. I know that these 9 improvement activities are something that practices are almost always doing, tell me not which ones you're doing, but which one your documentation would support in the event of an audit, so that we can report it retroactively. And it's always like the same few, either timely access to lab result or available continuity of care, access to a MIPS eligible clinician 24/7, and the medical record. Because almost everyone either has a call service or an after hours service that can put you in touch with the doctor. And doctors really have to timely communicate their lab results, otherwise people and that'll get you to a -2% penalty or a -1% penalty. I had a client in a do or die scenario where their penalty after doing that last minute work ended up being like 1% of a percent. They were losing on every $100 they were making from it, which is way better than losing $9 on every $100 for Medicare. But the fact that even possible isn't right. I'm happy to be able to help my client. I'm glad that it stayed within the guidelines of MIPS itself. It serves absolutely no one, because even at the end of the day, I'm building that small practice paying a registry vendor fee only so that they can lose 2 cents on the $100 to Medicare anyway. But it'll be less than the 9,000 plus they're going to lose when they don't report at all.
Yeah. Wow. It reminds me, to what you were saying earlier, just how much I hate the space. Okay.
I never say no to anything. This town, I was like, it almost broken me. It has taken me to the depths of despair. And said, here, let me hit you with some more shit. And that's when the anesthetic and the other not.
Yeah, let's talk about that real quick then. No
Don't even
Surprises
want to.
Act. No Surprises Act. Can you tell us some of the results? I guess some of the implications that it's had on your business. That No Surprises Act was implemented in an attempt to shield patients from out-of-network surprise bills and balance bills, and the intention was to what was it? Apply the in-network payment to all out-of-network bills, regardless of the patient's awareness to whether the facility was in or out of network. And I believe that was only in emergency scenarios, right? Where emergency scenarios and where the patient was not adequately notified beforehand.
Correct. Yeah.
But then how does one dispute, like the practice would then say, I told them that I was out of network and they came to me anyway, and we have this and this documentation in place.
That's exactly how they distribute it. They say it's not a surprise build because I'm the only one capable of providing this service. I am out of network. You came to me, understood, and signed our form indicating as much. Now, and then here's the part: you still don't really get paid. The payer's still going to try to pay you with the QPA. Got to go through arbitration. Got to provide additional documentation that proves why you should be paid more than that qualified payment amount, which is dirt low, 90% of the time. And after you've done all that extra work for a single claim, the open negotiation process fails to go do an IDR, and independent
data review.
I'm going to Google it. Independent dispute resolution process.
There you go.
Not there without Google. You have to go through that process, and whoever loses the process pays the fee for the IDR. Imagine you are an intraoperative neuromonitoring practice. You got 9 remote readers, and you got 8 techs in 8 different hospitals for the facility component that isn't tied to the facility, like you were talking about earlier. You put them in this scenario, and they send off a claim for like several $1,000s to Blue Cross Blue Shield or whatever payer it ends up being, and they get offered an amount based on the QPA, 78. You go back and you go into the open negotiation. 30 days to openly negotiate with the payer. The payer doesn't even have to respond to your intent. They could just leave it on red. And then after that, you have to file with an IDR. Now, the NSA acts as both the payer and the health plan, the filing with the IDR. But obviously, found overwhelmingly, the provider does it because it's the provider that's getting hosed relation.
Yeah, and they also use the QPA or whatever it is they use that to pay that across the board, whether or not it's valid or not. I've seen that on clearly scheduled and elective cases in the out-of-network world, where they were quite literally applying that. They would hide the remark code.
Yep.
hide the remark code, apply every single case in network to whatever that QPA was, and unless you called up and specifically unearthed that particular remark code that was representative of the surprise bill adjustment, good luck. And even then, it wasn't ever included anywhere on the remit, on the 835, nowhere. You always had to call.
Here's where it gets worse. I have more to add to this. For a single determination, a single claim, an IDR charges between $350 to $700 to the loser. Let's say I'm this small entrepreneur in my practice, and I failed open negotiations with the payer. I go to the IDR, I offer a number, I put it forward, the payer put the number forward. The payer has access to all the data from any IDRs that have come through for that payer. The provider only has access to data for the IDRs that they file. Who do you think getting it closer to the QPA and still not go over the other person's value?
Yeah, wow.
The provider doesn't stand a chance. I was the payer. I would look at all the reporting data. I would be like,
Yeah, they
okay,
do. Oh, yeah, they do.
90% of the providers are coming in at this dollar for the service code. I'm going to hedge it by $1 less. They're going to have the $350 to $700 single claim IDR fee, and they're never going to want to file with the IDR again because the system is self-defeating. Looks good on paper, absolutely benefits the payer, and it gets worse. You're going to go right back to how small practices get unnecessarily hosed versus the big ones that don't care. Listen to this shit. It's $475 to $938 for batches of IDR claims, but you only got 3 to 4 days to file with the IDR after the open negotiation process failed. So if you're a small practice, you physically can't use the batch process because you don't have the volume to support it. And if you're a big hospital or a big out-of-network practice that's too big to fail, you don't give a shit about the cost because you can do 20 to 30 at a time. That's what gets me. We love small business in America, but we love shitting on them.
We hate small practices.
Yeah.
Yeah, wow. That's for any out-of-network.
There's stipulations. I don't know all of them off the top of my head to speak with enough confidence to do your podcast justice, but there are like non-ERISA plans, different process, or they don't have this process yet. It, depending on what state you're in, you could either have a state-run process that's better or worse, or in 21 out of the 20 states have a state process. They don't have processes for all the different claims that would come under the no surprise tax. You have bifurcated process where you can elect into the state process in some states, and where you have to unelect out of the state process for certain claims that wouldn't fall under that state giving processes based on federal.
Would you say that, because I'm thinking about this now with my buyer hat on and the employer advocate hat, this wouldn't really happen in the context of the providers that we support and the employers that we support because there's a contract in place that we help negotiate between the two parties. And so that's the point of that direct contracting. But outside of that context, let's say in an area where there's a hospital that we might not have contracted with yet, then the patient's seen it's out of network because the provider doesn't have a network, or excuse me, isn't in network or doesn't have a contract with that particular employer or TPA, let's say. And so none of the hospital inpatient bills can get processed at an amount greater than the average or lowest, if you will. Yeah, exactly. In network rate. And so when brokers and administrators, plan administrators talk about claims that blow up plans, it's something that I've been questioning recently is what about the NSA and the QPA? Like, how is it that any of those claims are blowing up plans if none of them can be processed at a rate that's above that QPA?
What do you mean by blowing up plan?
So basically, quite like one of the biggest risks of any self-insured employer plan is that a patient goes either out of network or, goes out of network to a facility and gets care without the protection of a single case agreement or a contract, etc.,
Wait,
and will
go ahead.
go and get maybe like an inpatient knee replacement that could have been avoided for, I don't know, with the $250,000 stay
Okay.
overall. And then, so then the point is, okay, that'll blow up a plan that might only have 250K put to the side for the entire claims fund. And so that could have been avoided by a direct contract that contracts the total joint replacement at 20, 25, 30K.
Yeah. If the patient is out of network and doesn't have benefit and they fall under one of the plans that would fall under the NSA Act, the provider, the onus is on the provider because the payer only says, I'll pay you with the QPA, and you'll barely know if I did it depending on how I hide the work.
But I guess so then with what you're saying, and this kind of, I think this is the point, is that only TPAs that know to leverage that would really get the benefit of it. Because the TPA in this instance is the payer who is administering the benefits on behalf of the employer. The employer is the ultimate payer, but it's the TPA who's sending that remit. And in the instances that we're referring to, the TPAs, i.e. the ASOs, the Big Daddy Bukas and Carolines and Evernorths and all those big ones, they have the resources to apply that reduction. But the smaller independent carriers, or excuse me, the smaller independent.
They wouldn't have the data either. They'd be like small practices where they'd be in trouble.
Yeah, but that's the thing that I don't get is, and I think maybe it all comes down to awareness and gaminess. But if they're like the small practices, then why aren't they just doing using these simple opportunities to reduce payout? It's almost like in the self-insured world, and I'm sure you've seen this as much as I have over the last few years, but in the self-insured world, their incentive, it's almost there's some weird hidden incentive to pay more.
I'm not sure I follow that.
Basically, it's like if an independent TPA can avoid paying a large bill by applying one of those NSA remark codes, whatever, the QPA reimbursement, and they don't. Like, why are
I don't think they don't. I don't think they don't. I really don't think there's a system here where the NSA doesn't protect the payer more than it does. Okay, so to rewind a little, the NSA is designed to protect the patient, and to an extent, it absolutely succeeds in that because it is now pitting the provider against the payer, and the patient doesn't have to do a damn thing. Golf clap for the NSA. It did a little more than what MIPS did for what it's supposed to do. The bad news about it is that when you look at the legislation, it clearly benefits the payer. It benefits the payer 9 ways Sunday. And it makes sense if you think about it because the lobbyists had a hand in it. The lobbyists were well aware of when the rule was going to come into effect based on the sessions of Congress. So they had all the time they needed to sunset their bigger payer plan to reduce the QPA further, to make it more beneficial to them. They had all the time to start prepping how they would start looking at the data when it's coming in. And even a smaller, I don't think I would think they would love the end if they fall under it. The shaking your head?
No, like I just don't
Oh.
think that they realize that it's an option to exercise against these larger claims. And I guess then the real question comes down to where does the eligibility fall? And what do it sounds like you're gonna expound on what that looks like. Like,
So here, I have some data. I definitely have some data for you. Where did I put it? I gotta figure out where I bookmarked.
because it's wild. Like, I routinely hear about these claims, and the number one fear for all of these independent self-insured employer plans is that a few claims will come through and it will blow up the plan. I.e., you can have a plan that pays everything in cash and cash pay everything, literally, and that's become a big thing, believe it or not, which is wild. And you have 2 claims come in a plan period, and it can completely destroy a plan.
I feel like the plan has no incentive to pay it unless they're offering out of network benefits.
But that's part of the crazy thing, and it's cool to hear you say out-of-network benefits. Is like all of these self-insured employer plans all offer out-of-network benefits. All of them.
Okay, so that's the piece I'm missing.
And that's partly like their whole thing is that so they don't have contracts in place because they're not the bukas and they haven't done the work to go out and get the contracts. Some of them have, but
Yep.
most of them haven't. And so they will. Have you ever heard about reference-based pricing?
I've heard that expression, but I don't know enough to opine.
Yeah. So remember back in the day, and I don't know if we were together when I first started seeing these, but maybe we were, where you started to see remits that would reference some out-of-network fee schedule. And
Okay.
the response was, how's their fee schedule for out-of-network? Like that
There is.
those things don't line up. What do you mean? That's like
That's not correct.
that's an oxymoron. So what reference-based pricing is, and it's wild that it took me to coming into this side of the industry, the buy side, to really understand what was going on. And it's a wild realization once you get to it. Is reference-based pricing is a methodology. It basically takes the percentage of Medicare methodology, which we know coming from the RCM space is the prevailing pricing methodology for the entire fucking industry when it comes to commercial insured plans. It takes that concept and uses it against the insurance carrier to say, hey, carrier, where you don't have a contract in place with the doctors that are going to submit bills against your plan, we're the TPA, we're going to say that we will only pay a max amount of 175% of Medicare for any claim that comes through for that would otherwise be reimbursed at over that 175% amount. Most practices see 175 Medicare and they're like,
I'm okay with that.
yeah, that's good enough. Exactly. That's good enough.
Fucking sick.
That's exactly right. 1 out of 10 says, fuck you. We're going to court. And then starts this suing battle. And that's where I saw a couple of attorneys essentially just become part of the revenue cycle, where you pluck out certain claims based on their status. So is it an ERISA claim? Is it with this TPA or
So
that?
law.
You said that, not me.
And put them in the past.
I kept their name out of my mouth. I don't. If that's one of the
sit out of the industry.
If that's one of the attorney groups that you've seen in this context, then I'm sure of that. But no, dude, off the record, yeah, fuck yeah. University of Spine News College, they were part of the rev cycle.
So let me give you an answer before I lose track of the question. I haven't seen the situation come enough, so I'm not too familiar with. I do know that based on the type of plan, certain things don't fall under NS. But information here that leads me to believe that the NSA doesn't really have an impact on those because either they're exempt from the NSA for whatever reason, and then they may have to, like you said, risk paying a lot if they get sued, versus being a part of the NSA, there's some data. So the top 10 non-initiating parties for federal out-of-network disputes. Now remember, this doesn't even include state IDR, because they're saying typically the federal out-of-network dispute. From April 15th to September 30th of 2022, this is when the whole thing blew up and there was like 90,000 waiting in the queue or some nonsense. I believe this speaks exactly to those 90,000 claims. 24% of them were filed against United Healthcare. 14% against 11% against MultiPlan, 10% against Anthem, 9% against Cigna, 5% against Blue Cross of Texas, 4% against Clear Health Strategy, 4% against Florida Blue, and then you have 2% twice for Blue Cross Blue Shield of Illinois and Blue Cross Blue Shield of Tennessee. These are not small TPAs.
Yeah. And it wouldn't be that. Those numbers would be based off of overall market share. You'd imagine, just in terms of averages. But the Blue Cross of Texas one was interesting.
If a TPA is so small that it can't survive a lawsuit over 1 out of 10 of their claims that they decide to pay less because they have a poor business setup, that's on them, because no one has any freaking mercy for the small practice. If I had to choose a side, I'll burn every payer to the ground before I burn every provider.
Yeah, and it's interesting. That's the exact approach that I take also, where it's coming from the provider side. The providers are only doing that because they're not getting paid adequately. And because even when they are by certain payers, it's not across the board. And so all you have to do is create some mechanism through which to pay providers adequately. And you could pretty much all but forget those scenarios where they're going to sue you, because it's not like they're the devil and they want some unreasonable dollar amount. They just want to get paid without having to fucking jump through hoops. And that's the plight of the independent doc that is getting fucking wiped out. Those docs are getting wiped out.
Think about the not putting the dollars to the event. You have a reader and the technician, and the reader is paid whatever. They're probably making a few $100 for the hour or whatever, and the technician is making a few $100 for the hour or whatever. And then the payer, and that's not even the cost of the node that the technician is furnishing, or any
We're
of
talking
the other
about
metrics.
we're talking about
Cost. Yeah, all of that.
I was
And
going to say,
then-
we're talking about intraoperative neuro monitoring, just for everyone
Yes.
who hears this and is wondering.
A case could cost anywhere between $800 and $1,500 just to furnish resources and labor. And then some payer comes back and they pay $230 on 3 line items, outright reject 2 other, and ask for medical documentation for the last one. You have guaranteed that the provider and the RCN company are going to lose money over pursuing the money that they lost. It's such a viciously one-sided fight.
Where the biggest party that it protects against is the hospitals. It's the hospitals who are charging these outrageous rates. It's not even the docs. Yeah, in some instances, the docs. But the hospitals are really the ones that'll put you in bankruptcy, and it will blow up the plan. It's just wild.
Until the plan buys the hospitals so they can tell the doctors what to charge for their service. Just like Optum bought Care now.
Yeah, look, it did. Yeah, that's the fear.
Disgusting.
That's the fear. The only reason why that hasn't happened or that won't happen across the board is because the self-insured employers have started to defect from the traditional TPAs, the ASOs, the bigger ones, because of how much it's costing them. And so they're starting to see, okay, I can't continue to pay, this year over year increase. And so we have to take other action. We have to try something else.
I have a different theory for why it's being a failure, though. It's because the payers have no right dictating patient care. That's between the patient and the doctor. And the moment they buy the hospitals and dictate patient care, in order to maximize their profit, that's what the payer is, for-profit group. And the moment they start maximizing those profits, it means taking away from the patient experience. And when that happens, it inevitably will take an hospital and that provider groups that are owned by those payers and you want to know them because they're basically just hedge fund lackeys at that point and trying to squeeze out every last dollar out of it.
We could only hope that that's the way it actually goes, because that's what we've been seeing for the last few years. And I haven't seen some of those big hospitals go out of business.
I know they don't. They just get bought by another company or something. They can go.
It's insane. All right. I mean, I think on that note, we can wrap up and say it's safe to say that the industry is built on misaligned incentives that will only continue to harm both sides of the market, both providers and payers. And when I say payers, self-insured
RCM.
employers and the patients that are ultimately footing the bill for those benefits. But yeah, the RCM, of course, but like RCM is a necessary evil as a result of a broken system to begin with.
I agree. If you could actually file a claim in an amount of time as the doctor, you would.
Yeah, it's almost to say that the quality reporting programs are just another version of RCM that is essentially gone the same way that RCM did. Instead, right? Well, look,
Oh, I did.
the procedure, but it's true. The procedure codes, the diagnosis codes, that was all intended to drive population health management and reporting.
Standardized care.
Correct. Exactly. Oh my God. Wow. I just realized that myself. Holy shit. I've been like waiting for myself to pull that out this whole time. It's the same thing. It's the same thing. Oh, that's pretty fucked up.
My stance, ever probably since 3 years into working with you, and been the exact same as it is now. And is that if a new law came out, if it was single payer, if it was Medicare for all, if it was literally anything that was better than what it was today, and it would put RCM out of business, then I would gladly support it and live under someone else's porch just to see the change happen.
Yeah.
I don't care how badly it would impact me, as long as it.
Wow. That's wild to think about that CPT codes quite literally are intended to drive population health management. It's literally and we're
If you
trying
just
to.
have coded units, you can glean a whole ton of information about a patient population
Yeah,
instantaneously. Things
for
that
sure.
you can tell.
It's still, but it's not complete. Is the point?
No, it's not.
Just the same way that the current measures aren't complete. It's the same thing. Only they just redid it and repackaged it.
They're a little better though, because you could look at all the gastric bypass surgeries done in a the area and instantly know more about a patient than if you looked at the MIPS data codes they were reporting for.
Yeah, amen. Ain't that the truth?
Yeah. You would know they were obese. You would know that minimal invasive intervention didn't work. You would know that they were of a certain age where they qualified for the gastric bypass or whatever. If you report the quality data codes for BMI or whatnot, you don't even necessarily know if they were bad BMI or good.
Yeah, that's all we could do is try to fix it. And I
agree.
think it's gonna the best way to do so is outside of the bounds of the conventional reporting methods, whether it be RCM billing reporting or the ECQM reporting, quality measure reporting. Those just don't work. And if they do work, they work for a portion of the population that isn't representative of the whole, or maybe it's just viciously skewed. But to your point, it's not the whole. It's a subset. And yeah, God bless us. You have to rip and replace is the only way.
And the solution, and this is obviously why I had to press you to do this stuff years ago when you were still working out the ideas of the king, it has to come from a third party that wants to compete in the same environment. Because if you look to beware, if you look to the government for a solution for this, it's never going to happen, because it doesn't matter whether we end up with another Biden administration or another Trump administration or even that other guy who's running independent.
Kennedy, yeah.
The lobbyists are the ones who are writing that policy. When the Texas Medical Association sued the Department of Human Health and Services or whatever it was for the NSA, there was two big reasons. One is because the QPA was not indicative. It was not a reasonably indicative financial point of measurement for what should be paid. And two, that they didn't even allow an open comment period to dispute it, like they're supposed to in the final rule. TMA won. Then, in the same year, I think it was in August of 2022, the Biden administration proposed a new final rule that made the QPA not only for measuring it, and then TMA said, no, that's not enough, and they sued again, and then they won again. And now there's 5 different lawsuits going on. The whole system is like partially frozen. Certain ones prior to a certain period can still be providing you open the negotiation period when you were supposed to, even though the payers had no obligation to respond during. And then you can, now that they're back open, you can get those taken care of. And that's what the pro-health industry administration, it doesn't matter in charge at that point. The lobbyists are going to write the code, the legislation.
So then, to what you're saying is the best way to resolve the problem is for it to come. You said from an independent third party. I'll do you one better. It's to come from the people.
Yeah, beat the crap out of them in the open market. That's the only way.
Agreed. That's it. We can't. There's no other. No one's coming to save us.
No, I could imagine a scenario where it eventually happens, but how much work would it have to get first?
Yeah, but
when props up our go ahead.
Even when it does, what are they going to replace it with? They don't have. If they had a solid alternative, they would have put. Exactly. They had a solid alternative, or alternative, it would have been put in place already.
It's just tough for me to stomach the statement that healthcare is for profit, because when it does, the ones with the most profit are the ones writing the rules.
Yeah.
And we know how much the healthcare group made in 2023. It was like $268 billion. And then Optum, which is another platform of United Healthcare, made $224 billion or something. And then Change Healthcare, which is another platform of United Health Group, made $3.48 billion in 2022 or some nonsense. Like they have more money than even some of the biggest hedge funds. They can afford to lose it experimenting, figuring out the system, to getting the policy right in their favor, to dragging it out as much as possible because they are making money on the interest.
Yeah.
If you're small, Even if it's like smaller than even hospital side, even if you're hospital side, you still have a bottom line you have to deal with. You can't possibly compete again.
Nor should anyone have to. Like
Yeah.
and what for what? All because it's not like they're actually shielding people from financial ruin anymore.
No, no.
And so
Our
essentially
deductible is huge.
exactly essentially they're just a gateway. And it's okay, you need this to get access. They're the access gateway. And for what reason?
The part that really makes me nervous, and it's a bit of a tangent, is that the bigger these companies get, the easier they look to hacktivists and cyber scamming and ransomware and all that. And we're only going to see those attacks increase as time goes on. Change Healthcare had to pay $22 million and they still didn't get their data back. Who gives a crap? They made $3.48 billion. The people in Caramount who are now working for Optum, who are absolutely impacted by Change Healthcare, aren't even aware because their paychecks are still coming. The fact that Change Healthcare isn't working they don't know about that. Their claim, Optum gets them because they're literally owned. There's no screwed by the Change Healthcare ransomware. Me. We're still not getting ERAs that we were supposed to 4 months ago. I'm exaggerating at the point.
And it's wild because the only one, like you said, the only one who can withstand such a hit in terms of cash flow and flow of data is Optum.
Yep.
And so they're almost incentivized to let this happen again because the whole industry stops and they're still writing checks to their own internal people. If anything, it has those people singing a happier tune.
Longer for money to have to go out.
But it's also, maybe I should have been employed this whole time because all of my counterparts who are in independent practice, they're scraping for pennies now. And I actually have a paycheck. Maybe this is the way. Oh my God, saying that out loud is fucking disgusting.
Gross.
Well,
but we've seen that since the dawn of time. The bigger company always tries to find a way to gobble up the smaller ones, whether it's the hospital bullying providers to bring them under the hospital's fold, or the payers bullying the hospitals and the small providers and small practice. And if there's more money to be had,
yeah, they're gonna continue to squeeze. Well, I think that there's only one way out of this mess, and we will work to see that it gets a fighting chance.
The joke is terrorism, but I don't support that. Yeah, no, I agree with you. I hope to see it in my lifetime because I would love to see some of the bigger payers get a little uncomfortable. I would love to see them trying to adapt to a competitor instead of the other way around.
Yeah, imagine. Let's do a quick number real quick. If we took 1 million of their members,
which isn't even a lot,
even just 1 million, and we did. That's not even. See, so the crazy thing is when you look at the actual admin fees of TPA costs for ASO costs for some of these groups, 1 million members paying $25 per employee per month or 1 million employees paying $25 per employee per month. That's $300 million in just standard claims revenue. If that's what the TPAs or some of these ASOs are getting, like, then the numbers don't add up because where's the rest of that? Where's all the revenue coming from?
More than $25.
No, it's not. That's a publicly known like average, and frankly, that's on the high end.
Oh.
So basically, what I'm getting at is, and this is what I've been working on a little bit, is that it's not just the admin revenue. They're taking money on. They're making a spread, and so they're upcharging the employers, the actual ones who are paying the claims, upcharging the employers and paying the docs the same amount of money. So basically, and I've seen it now, I have proof of it, where there's on an ASO contract from Anthem, I'll show it to you. It says traditional network discount fee that the employer pays Anthem 50% of the difference between the billed charge and the allowed amount. So i.e. the discount that is negotiated on behalf of the member between.
Sidebar.
Yep.
What stops because I think we had this conversation before, but it never really made sense. I knew that as a provider. What stops me shooting my fees through the roof every other year?
Nothing, but in this instance, you already have a contract, so why would you?
Sure. Okay. I guess that's what stopped me then.
And
That's how they keep it managed. That makes
but at the same time, it's also like they have to do something to incentivize doctors to jack it up, because then the whole thing's fucking sick. But my point is that if you think about that, think about like carpal tunnel. I always use this number where $2,000 enhanced reimbursement, $10,000 charge, $8,000 savings, 4,000 of that is that traditional network savings fee. So the ASO gets $4,000, the provider gets 2, and the employer's charged 6 instead of 2. That's where all the bloat is gone. All of it in our country. They say that 30% of our spend is attributed to, what do they call it? Pricing failures and administrative complexity.
I believe the latter one. Pricing failures might need it. Just not realizing what's going on.
No, that's the thing, is I think that whoever said that word knows exactly what's going on. Because frankly, everyone that I've talked to that has any bit of insight into this space knows that's exactly what's happening. It's sick. You know who? I'll say this and we'll cut it out. But you remember the dude from Instamed? Actually, I don't know if you ever met him, but
I heard the name. I've heard you complain about him.
So it's not him, because I wouldn't have complained about him because we didn't really work closely with him, but I stayed friends with him and I spoke to him recently. He's now the president of, oh no, he's the CEO of Instamed.
Oh, good for him.
He took over for the OG guy and is now not only the CEO of Instamed, but the head of global payments, the head of global healthcare payments for JP Morgan. Because
that's
Chase,
such a big, the numbers, I couldn't even fathom it.
Because Chase bought Instamed like a while ago, and they just rolled up Instamed into their
banks can buy.
They bought them for the customers. It's interesting. I thought the same thing, and I wondered, and I did some digging, and it was because they literally just bought Instamed for all of the banking customers. Easy way to get in with all those docs to say, hey, we see that you're using this company to transfer payments. You want to just open up a Chase bank account instead?
Oh my God. I hate it. And the consolidation kills competition, create leveraged relationships where you can do all sorts of heinous bullshit and get away with it because your dollars that are speaking more than the smaller person in the relationship.
My point is,
outraged.
When I asked him about if he knew that this was going on, you know his response was?
Of course.
He said, yeah, how do you think they make money? And then when the multi-plan article came out in the Times, did you see that?
I did not. And I would like it if you want to send it to me.
Oh, you should read it. Yeah, that's good. Because we're about to do the same shit with ProPublica, but for in-network reimbursement, because that's what they're missing. And I almost think that they pushed this out there just to distract from the real problem. But hit me up and was like, when he saw that, he was like, hey, I just want to make sure you saw this. I was like, oh yeah, I saw it. I told you. Because I asked him and he was like, yeah, dude, what the fuck do you think is happening? What? What do you mean? Insane. Yeah, we're fucked.
My joke was, like, I didn't know where cards were gonna fall at the end of the day because everything is at the struggle the last 4 years. But I had an out. If this didn't work out, if medical billing wasn't for me, I was gonna go write month. I feel like I could do any of it. I was literally gonna go make $1 million today writing month because that would be easier than dealing with the pay. It was more successful because I wouldn't have to leverage resources and whatnot as a smaller entity because my ass can still run over it.
Yeah, it's a losing battle.
Absolutely. Every time one of my employees goes and has to look up ERA manually in a portal and do multiple clicks and find it and then batches like that instead of it coming into my EHR like it's supposed to, because Change Healthcare, a clearinghouse, I don't even use, is required for the forwarding process because clearinghouses have to talk to each other instead of directly to the connection that's supposed to, because again, they want
exclusive,
their proprietary
exclusive partnerships. No, it all comes down to exclusive partnerships.
Oh yeah, 70% or something of Change Healthcare contracts are exclusive, meaning they can't go anywhere else, even during hacking of. Yeah, okay. You're costing me time and money, and I have no recourse. Nothing whatsoever. Suck it up. put more man hours on the job to get it done and take that hit.
Yeah, look, that's why it got to the point where I was like, I'm not going to comply with this shit anymore because we're all fucked.
Yeah.
We're still all fucked, frankly. Until the end of this year, until next year, hopefully this next couple of years, when we start to come out swinging, then there'll be a little bit of a maybe, but even then, we're going to have to fight the fucking battle of a lifetime with the payers.
Tell me what you need me to do. I will make sure payers.
Yeah, good.
Just don't report that comment to die because I'm feeling literal.
Come with that attitude in 2 months, and we'll tear the bitch down. It's already in play. We just have to not fuck up.
That wraps up today's episode of Off the Rails. Remember, you can find us on Spotify, Apple Music, YouTube, and other major podcast channels. Don't forget to subscribe to catch all the content. If you like what you hear, please leave us a review and share it with your friends. Your support means a lot and helps us deliver more authentic takes from real change makers. Follow us on Instagram at GoOffTheRails and follow me on Twitter at Sydney Haytalk. Thanks again for listening. Stay genuine and stay true.